I'm co-founder and president of Needle Point Sanctuary, which has been around since 2017, and first began as kind of an illegal syringe service program and Narcan distributor, but we're a licensed syringe service program. We're allowed to actually have needles and Narcan now. I'm a high school teacher. I teach social studies classes, and I'm a community activist. If you want to, at any point, just raise your hand and interrupt me and ask questions. We can make it interactive as you'd like. So, what are opioids? They're naturally derived synthetic drugs that bind to our opioid receptors in our brain. So, we actually, in our brains, have opioid receptors, and when we do opioids, the opioids actually bind to that, and that's where you get the feelings of euphoria and the feelings that people, well, pain management and kind of the euphoria that goes with feeling calm and ease of pain. So some of the common opioids are heroin, fentanyl, oxycontin, Vicodin, carfentanil, morphine, codeine, hydrocodone, methadone, buprenorphine, naltrexone, many opioids. The one we see the most on the streets is, of course, fentanyl and then heroin. But heroin's kind of increasingly faded out more as time goes on. It's a lot more expensive than fentanyl, and dealers don't make as much money. So with it being an illegal market and they want to profit just as much as the next capitalist does, they're going to cut costs. They're going to cut costs even if it impacts safety and dying. So it's just kind of the nature of a decriminalized market. Like Willie was saying out there, when alcohol was prohibited during the era of Prohibition, it very quickly went from having 40% alcohol, where you knew exactly what you were getting, like you go to a store and get, and it ended up being that moonshine. People would produce the most potent thing that they could get, 95%, the Everclear, I just said moonshine, right? Moonshine. This was kind of dominated the supplies, and people were dying. People were overdosing from alcohol because it was less safe. People were being poisoned, and it was a very illustrative example of, even in this society, what we're doing when we criminalize heroin and naturally invite other opioids, much more powerful opioids like fentanyl, into our supply. So as we can see here, the different types of opioids and kind of how potent they are compared to heroin. So all dosages up there compared with 10 milligrams of morphine, you can see that fentanyl is 100 times more potent. So an average dose of heroin, medicinal is about 5-10 milligrams. Recreational is about 30 milligrams. So somebody puts up 30 milligrams of powder onto whatever they're using to do their dose, and they actually have fentanyl, and it's 100 times more powerful. That's how we lost Will. That's how we've lost so many good people in this struggle. Interesting too, like heroin, diamorphine, was synthesized in the 1920s, and basically a chemist just took regular old morphine and made it a bit more fat soluble. So what heroin does when it breaks down your body is it's morphine. Basically, you're on a morphine high when you're on heroin. So we can even just use that simple fact to destigmatize heroin. Many people, if you've been in pain and been to the doctors, may have been prescribed morphine. It's very similar. You were just given a medicinal dose and ideally didn't become dependent on it over time. So recognizing the signs of an overdose, biggest misconception of heroin overdoses is that the pupils are going to dilate. They think similar to like a meth usage or something like that the pupils will be very wide and you'll be able to tell. It's the exact opposite with an opioid overdose. You see the pinpoint pupils. That's a textbook sign that somebody's high on heroin, and it's the biggest tell. If you know somebody pretty well, you can almost, as you get used to it, you can kind of pick up when they're high. So recognizing the signs of an overdose, people are cold to the touch, unresponsive. The best indicator is if they aren't responding to anything, that you can be fairly certain it's an overdose. Hey, what's up?
You'll also have like clammy skin.
That's right, clammy, cold to the touch. You'll also develop bluish hue on your lips and in your face. Color will leave your face. There are some telltale signs like the gurgling too. It can be a little difficult sometimes to recognize when somebody's just nodding out, which is a very typical phrase that's associated with heroin use. People in the euphoria start to kind of nod out, and sometimes that may look like that they're overdosing. The biggest thing at that point is if you know somebody's like using and you're just not sure if they've overdosed or if they're just nodding out, it's definitely the responsiveness to touch. So if you are high and you're nodding out and somebody shakes you, you will come to and you'll kind of be like, oh, you'll process what's going on. When you're overdosing though, you can shake somebody and they just won't. And that's a really good telltale sign on top of the bluish lips. That's also really common in people who have started to overdose, is that even at the end of their fingertips, and I think the lips are the easiest telltale sign as well. Yeah, and if the individual is struggling to breathe, opioids are central nervous system depressant, which means they slow down your breathing, they slow down the blood flow, and overdosing is basically kind of just, you get to a certain point where you just can't stay awake anymore and you simply fall out onto the other side. So overdose or just nodded out. So since opioids create a sense of euphoria for most users, when users get on a recreational dose, which I classify as basically anything past a medicinal dose before an overdose, they may start to nod out. And that may look like somebody's just kind of falling in and out of consciousness. It can look like, though, that they're overdosing. So it's important for the signs on the previous page. Definitely the sensitivity to touch is your number one ability to tell if someone's overdosing. So in almost all cases, you can shake someone who's nodded out and they will respond. They may not get up and be like super coherent with you, but that's fine. At least they're awake. And at that point, you know they're not overdosing. So if they don't respond, that's when your alarm bell should start ringing that this is an overdose, not somebody simply nodding out. Any questions about that? I know that can be hard.
With a person of color, is there a different way of recognizing that bluish tone to like the fingers, the skin, the mouth?
That's a really good question. Not something I've seen in Maine all that often. At that point, I don't fully know if like the lips discolor. I've never actually reversed a person of color. It's always been just white.
I have a medical background. Typically, you'll see more of like a grain versus blue. It'll be any form of the loss of like melanated areas will become more opaque. Okay. Kind of like an ash type of thing.
And you can tell kind of like inside mouth better.
Okay.
Oh, right.
Yeah.
That makes sense. I'm learning things too. So rescue breathing, this is a tactic that you'll use if you're pretty sure somebody's overdosing. So to do rescue breathing, which is different than CPR and different than heart palp or doing the thing. With rescue breathing, you're just checking for airflow. So with rescue breathing, check to make sure the airway is clear. Once you're sure that the airway is clear, that's when you pinch the person's nostrils with your thumb and your pointer finger. You place your mouth over the person's mouth, making a tight seal. In some cases, there are things that you can use to make it a little less personal, but if you're just responding to an overdose, sometimes you'll have to do mouth to mouth. You breathe into the person's mouth with a firm but steady breath. So you're not blowing a bunch of air as hard as you can down their throat, because that air can bypass the trachea. It can enter the stomach through the esophagus and can lead to people throwing up, which is almost the exact opposite of what you're trying to do. So, if the chest does not rise with the initial breath, you retilt the head and you try again. If the chest still isn't rising, the person may be choking, and in such a case, you would need to check the airway again and clear whatever debris is in the way. Immediately place the person into a recovery position after delivering a few rescue breaths and prepare to administer naloxone.
What is the rescue position?
We're about to show you the rescue position for sure. Yep, definitely, great question. So this is rescue breathing right here. This is pretty much effectively what it will look like. You can see well, you can't see the thumb, but the thumb and the pointer finger are around the nose, and the other three fingers are kind of resting alongside there for balance. And then you open up the person's mouth. You can keep your bottom hand kind of look like that, and also like this. It really just depends on what you're comfortable with. You just want to hold their head very steady as you're administering the breaths.
Are you pinching your nose?
Not pinching, not like pinching hard, but you
like
are
just
kind of
like
just
this?
using it to guide, to direct. And you want to hang in there because you may be very anxious. I remember my first reversal. I mean, it was hard not to panic in the moment. I didn't know if I should administer another dose. I didn't know if I should continue to do rescue breathing, which I continued to do both. But you want to hang in there. Sometimes the Narcan can take a few minutes to actually kick in, and you actually get someone to revive.
Is there a trash can around here?
There is right outside.
I gotcha. There's also one right over there. But yeah, it can take a few minutes sometimes before the Narcan actually starts to rip away the opioid receptor. So much like Opioids, when you do them, they'll bind, so they'll kind of like bind together. What Narcan is doing is kind of ripping that bind apart, which can be a little unpleasant for the person. We'll get to that. But it may take some time, so you want to hang in there. I remember if you're not sure about how long the person's been out, I remember we had somebody drive up in a car one time, just right up to Camp Hope, and it was like, this person's overdosing, and we didn't know, we weren't 100% sure how long they had actually been out. And in that case, we did end up calling 911 and just kind of checking in with the police. Because in some cases, people will need a lot more of an intervention. If they've been out for a lot longer, they may even need to go to the hospital. So if you're not sure how long someone's been overdosed, that may impact what you're doing. So the recovery position, which was asked about earlier, looks a lot like this. So you have the person's hand supporting their head, and you have their elbow kind of on the ground like this. I'm tempted to get down and show you, but I'd rather not. But you put someone on their side, and then this knee right here is to prevent them from rolling onto their stomach.
You want to volunteer to
Yeah,
demonstrate?
do you want to? I suppose I.
I was gonna say I will.
Excellent.
Are you okay with this on YouTube and stuff?
Yeah, sure. Sorry, unconscious.
So we want to get them up on their side, and the reason that we don't want them to stay on their back is because if Luke starts vomiting right now, there's not a whole lot of chance that Luke's going to be able to survive this. So he's not going to be able to help. So we're going to get him up on his side, and we're going to use this hand right here, get it underneath so that he's on his side right here. Then we go like this, and we want to get the knee out like this and bring the other one back. And this one is to prevent him from falling over and rolling over onto his stomach, which isn't as big of a deal as being on their back because theoretically the vomit will go on the floor, but still can lead to risk. The reason we do this right here is because if theoretically Luke were dead, he would stay just like this. He would never fall onto his back, he would never fall onto his stomach, he would just lay lifeless like that for until someone moved him. So that's why they've come up with this position as the recovery position. So that's what we recommend people to do. It's the safest way to ensure that someone's not dying on their own vomit. You can even do that with like alcohol overdoses and stuff. Thank you. Yes. Thank you. And you want to stay with the person, so just not down here at the bottom. If you leave them at any point or if they're unconscious, put them in this position to keep the airway clear and to prevent them from choking. Any questions about that recovery position? This is kind of another demonstration right here of what you're trying to do. And again, the point is to keep them from falling onto their back or even falling onto their stomach. Keeps the airways clear, prevents the choking on vomit. So in this example right here, we see it might be just a little bit better if they were to shift the person a little bit more onto their side, because if this person may let this person just go and just leave them unattended, maybe to go call 911, it's possible that they roll over onto their stomach, that the airways become a little bit more constricted. Stomach, again, is better than the back, but just in this example, maybe just a little bit more on their side.
I'm getting ahead of us a little bit here, but if we need to administer naloxone, is there a difference, or is it better to do so in recovery position?
Yes,
or versus-
absolutely. Yes, we recommend that people do, if you can. Now, there's a lot of, that person that I was telling you about that showed up in the car, we felt it would have been too much of a risk, maybe even to her neck, if we just kind of pulled her out of the car. It was a very cold day, it was in the middle of winter, and putting her down on the ground. We thought that it could be a little too risky for that. So what we did is we ultimately just admitted the Narcan right while she was in the passenger seat.
So if you can do it in recovery position, great. But
If you can do it in recovery position, that's what we recommend. That's the best way. Yep, absolutely.
I wouldn't do it if they're laying on their back. Like, I would make sure you move them somehow, because the likelihood they're gonna vomit is pretty high.
got it. Okay, that was I was wondering, like, how long does that happen? Okay, continue.
What if you can't put them in recovery? Like, say you're alone with someone, like an adult, that you can't get them into the recovery position.
You just do the best that you can to get them up on their sides, and then at that point you probably wouldn't want to leave them, and you probably want to call 911, especially if you're feeling like you can't alleviate the emergency on your own. Definitely good question. So yeah, in this example right here, it might be just a little better to put on the side, but the arms are all good, and and the knee is even pretty good too. So Narcan versus naloxone. Narcan is naloxone, so Narcan's the brand name of the nasal formulation of naloxone, and naloxone's the name of the medicine itself. So say administer Narcan, administer naloxone. It's really not all that different, but naloxone is technically the drug name, and Narcan is just the most popular, best advertised version of the drug. So harm reduction organizations should prioritize distribution of intramuscular Narcan because it is a bit more effective, cheaper, and contributes less to precipitated withdrawal. But as a harm reduction organization, we pass out nasal Narcan, and that can be just, some people are more comfortable administering nasal.
Yes, and we also have, out at our table, you will notice, we have Revive as well as the intramuscular naloxone. Revive, so Narcan is a 4 milligram dose of naloxone, whereas Revive is a 3 milligram dose. And what we've noticed in doing outreach, the feedback we've received is that it causes much less, the reaction is not nearly as strong to Revive as it is to naloxone. It is because of that 1 milligram difference. So if you all are interested in getting some, we do have
Which can also make it a little more tolerable for the person who has overdose coming out of the overdose with a little less Narcan. Because again, the process of Narcan, it's not like a violent process, but internally it is kind of like ripping apart binded receptors, you know, and it's a little uncomfortable. It's a little uncomfortable.
Is there advantage to the higher dose? Like if someone's in a severe enough overdose, would 4 milligrams be more likely to help them, or is there no downside to going with like using 3 instead?
I mean, there's not really a downside with going with 3. There could be, you might have to use another dose. That is like, you know, if 4 is what someone needed and you only gave them 3, then you would have to do 6, I guess, if you do 2. So you kind of see, it's like, it's kind of weird.
Also,
yeah.
with the IM, what's the best place to inject?
Best place to inject intramuscular is up here in the deltoid and then down here in the thigh, which we'll look into that right here in the next couple of images here. So how to administer intramuscular naloxone. So once you've identified someone's experiencing an overdose, you get them into the recovery position, and that basically prevents them from aspirating and choking on their own vomit. And then the best place that I've found is the deltoid muscle, which are these muscles right here. Train when you do that exercise. This is a very direct way right to a muscle. So, and that's definitely something to not confuse it. Intramuscular is a little different than intravenous. So intravenous is through a vein, and intramuscular is through a muscle. So you're looking for the easiest accessible muscles on both the arm and the leg, which is the deltoid and then the thigh right here. It is good to go. So IM syringes go through most clothing. If the person's wearing a heavy winter gear, it may not get through, or it might even break the needle tip too. So I remember that instance that I keep referring to up at Camp Hope. We administered through a pair of jeans because there was like 3 or 4 upper layers, and we were considering even cutting through, but it ended up working out that we were able to learn that there was just 1 layer on the legs, and we went after the thigh dosage. But yeah, it can go through most clothing. I would not try to put it through like leather. It won't. It'll break the needle tip. So you kind of have to make a decision in the moment of where's the best place to administer. Is it the deltoid? Is it the thigh? And that's really your 2 best options. So you really want to try to make one of those 2 work. Do you have any recommendations for?
So I would actually recommend avoiding the butt. They don't really recommend that anymore because of the risk of getting sciatic nerve.
Sure.
So on skinny people or old people or like malnourished people, I usually go for the thigh because if you're walking, like if you're someone who is able to walk, you have at least some muscle in your thighs, and it doesn't really matter anywhere like on the outside of your thigh where you can feel its muscle. You can go there. It doesn't have to be a specific spot. And then for the deltoid, you can feel like they have a bone here, which you don't like it. But if you if you cover it so that your, like this part of your hand is on the end of the bone, it kind of makes like a triangle.
was saying, the cup with the C is a very good kind of, to get you past like this area where the bone is and get you down where definitely the muscle is. So that can be a good little thing to remember. It's just,
It gives
the
you
C.
kind of a target to aim for.
What would happen if you did touch the bone?
It's just, well, I mean, as long as they're actually unconscious, they won't really care. But if they're kind of in between, then it's going to hurt them a lot, but it's just not going to absorb as well as if you're in muscle.
You break the needle.
You could, but only if you're like,
You really gotta stab it.
if you get real aggressive with it.
And it's okay to get, if you're not sure how many layers and you're just trying, it can be okay just to get it in there, because if the person's genuinely overdosing, they're not gonna feel it until afterwards. You'll see some soreness in the arm, especially if you get down to the bone. People will be like, but much better than dying. Much better than
Yes.
dying. So, utilizing intramuscular Narcan, you're gonna identify the overdose. Listen for the breathing. That can be a good
Just
indicator.
leave it.
If they aren't breathing, you can do the quick 2 to 3 rescue breaths and get them into the recovery position. Yeah. Do we have some I can get one out just so you can kind of see what we're talking about. These are the kits that we make, by the way, really cool. 2 intramuscular syringes, 2 of the 4 doses of Narcan. This one has a purple cap. This is the cap right here. So you're removing, in this case, the purple cap from the naloxone vial. And I'm not going to go any further than this. Just I don't want to waste the dose. Not waste the dose. You unwrap, you prepare the syringe. You put the syringes right in the kit. And then what you're going to do ultimately is you inject air into the naloxone vial. So you take out your intramuscular syringe, you stick it into, let's see, there's like a little area that you can actually stick a syringe in. So you may be thinking, isn't it just metal? No, they make a little area. The tip of the syringe can go right in there. Inject a little bit of air into it, and then you can actually flip it over, and then you can draw up the dose of Narcan, just like that. Administer it into the muscle, arm, leg, thigh, or butt. The deltoids typically are the ones we recommend the most. The thighs are second. Continue rescue breathing, and if they haven't come to in about...
Do you use the full bottle?
Yes. Yep. Every single time I've administered one of these naloxones, I've just used the full one, just because you can't really know how far someone's fallen out or how deep, how much they'll need. Just use the whole thing and.
Is it as quick as like doctors do shots, like in and out?
Yeah, it's that quick, and the person who you're administering it to won't feel it.
It's very much like your EpiPen, very similar, and like you put it in, inject it, and be done.
Unless someone does it really slow where it hurts.
Yeah, and luckily the person's never really going to feel it that you're administering it to, especially if there's genuine overdosing. They won't feel it at all.
Oh, really?
Yeah.
Recommend using the Narcan. If somebody hasn't come to, then I think the first time maybe waiting like 3 to 5 minutes, but you want to wait about between 3 to 5 minutes in between Narcan doses. Because if you just get in the habit of just winding up one and then doing the next one and doing the next one, and you've like put like 16 milligrams into the person, and they only needed like 4 milligrams of Narcan to survive, then it very well is going to impact them coming to and how pleasant they may be going through the precipitated withdrawals, which we'll talk about what that means here.
I have a question, if you don't mind me asking. I know the nose one isn't harmful, like if you do a bunch of them in a person, but what's the difference between the Narcan nasal spray and the needle?
It's the exact same chemical, exact same everything. It's just a matter of the route of administration. So the nasal, you just put up the nose. You don't even necessarily do trainings for the nasal, because it's just so very obvious. You got your dose and you just stick it in the nose and you just hit the button. Life goes on. With the intramuscular, it's a couple extra steps, so we can show people, especially in full-on naloxone training, exactly how to do it with someone who's in the recovery position. Calling 911, you definitely are legally obligated to tell you to call 911. it can be a discretionary call if you know more about the circumstances about the person who's overdosed.
There's a
I.e.,
bathroom.
maybe you watch them overdose, you know it's only been a couple of minutes, you do a dose of intramuscular Narcan, and they come right back to, again, legally obligated to tell you to call the police, but in some cases it's a discretionary call. So here are key injection sites on the bottom. So the deltoid and vastus laterus. So the more body fat the person has, the deeper the syringe has to go into the muscle. And make sure you get it into the muscle. It's okay to poke a little hard. It's okay even if you do touch the bone. You just got to make sure you get it into the muscle. IM syringes will go through anything up to a winter coat, but not leather jackets. The most important thing is to make sure the injection gets into the muscle. Don't sweat the small stuff, like I was saying. If you poke a little too hard, again, the reversal of the overdose is your prime, of utmost importance in that situation. Where do you dispose the needle? We just keep the needles. Where would we tell people to dispose the needle?
I mean, a lot of places have sharps containers in their bathrooms.
Yeah.
But, I mean, you can also just put them in like a soda bottle and throw them in the trash.
Yeah, I usually put them in like the laundry, like the Tide little.
Yeah.
Like,
Anything that's like a sealed container.
A sealed hard container. Don't just throw it in. with
I
the
know
trash.
they had a couple of those like containers out the tables.
Yeah.
Right. Yes. Yeah. That would be good. I know what you're saying is kind of like if you don't have any access to that and you want something just on the fly, then maybe around the house, maybe like laundry detergent or just something that's plastic. Even a soda bottle, like Megan was saying, you
Like
drop right in some sort of plastic container. Yeah, don't use the same syringe twice. Sometimes they have to be tightened. At Uniform Sanctuary, we do the tightening, so it's just a matter of grabbing the orange thing here. You don't necessarily have to memorize this, but in some cases the needles do need to be tightened. And don't use the same syringe twice for injections of naloxone, and that's why we give out 2 syringes for each vial, or 1 syringe for each vial that we give out. 2 syringes, 2 vials of Narcan. That's what we call a Narcan kit. So how to administer nasal Narcan, I don't really have to do too much explanation. One thing to remember is to get them into a very stable position. So you can see there that the person is holding the neck, keeping it very stable, and just putting the end up the nose, and then this right here is a button, and you just push the button, and that is the easiest way to administer to administer Narcan. So that's why we offer to both. Some people don't really want to carry nasal naloxone, and some people would rather have intramuscular.
So what if you insert one or the other and it's not working? Is it okay to use the other version of it?
Definitely, 100%. Yep, all the same chemicals, so you can go back and forth. You know, it's totally okay. But we just recommend people to wait 5 minutes or so in between doses because, again, it can take a little bit of time for the overdose to be reversed, for the receptors to have the binding ripped apart, and you just don't want to administer